Welcome back to the emergency department, everybody. Today's case, 77-year-old male. He's triaged as an ESI level 3 to your area. Complains of a sudden onset of abdominal pain. He's a hypertensive, a smoker. He's got history of atrial fibrillation. He's currently not being anticoagulated because he doesn't have access to meds right now. The pain, severe and constant. Says it doesn't radiate, no trauma. He says it came on just like a switch flipped. Vitals, kind of borderline. Heart rate 102, irregular. Blood pressure 166/95, saturating 97% with a respiratory rate of 24. He's uncomfortable appearing with a pain score of 10 out of 10. Exam, surprisingly a soft belly without tenderness, no guarding, no rebound, and yet he looks awful. So 10 out of 10 abdominal pain with a soft belly. Here's the first pearl. Watch out for poop. And no, I don't mean your normal avoidance of any kind of code brown situation in the department. I mean poop. Pain out of proportion, in this case, to exam, should make your emergency clinician brain scream one thing: mesenteric ischemia. It's rare. It's deadly. It's either missed or there's a delay in diagnosis all of the time. And you don't get a second chance. It's not on you. If it's not on your radar when you're tired, when you're 4 charts behind, when you just want this belly pain to be simple. But a diagnosis like mesenteric ischemia has no patience for your shortcuts or forgiveness for your complacency. So let's dig in. Mesenteric ischemia is any compromise of blood flow to the intestines. It comes in multiple flavors. So there's arterial occlusions, an embolus or a thrombus in one of your arteries feeding your intestines, or a venous thrombosis. And lastly, non-occlusive. So low flow states like septic shock or severe CHF. In our patient with atrial fibrillation who has not been anticoagulated in quite a while, it is a classic setup for a superior mesenteric artery embolism. The problem? Early signs can be subtle. Abdominal exam might be soft, vitals might be okay, but inside that gut, tissue is dying. So how do you catch it? Think about it in every older patient with abdominal pain. Ask about things like AFib, recent embolic events, things that would make you think they're in a hypercoagulable state. Don't wait for things like bloody stools. That's a late finding. This isn't the patient that will necessarily have gross blood, melena, or even a positive stool guaiac. What about the lactate? A rising lactate equals tissue hypoxia and a clue to dying tissue. So you definitely want to check for that if it wasn't part of the initial order set. But don't be reassured by a normal lactate. It can be normal in 50% of patients upon their initial arrival to the ED. Get an order for a CT angiogram with contrast. Make sure radiology is called, that your provider is telling them what to suspect, either verbally or when they put in the order request. That call can increase diagnostic accuracy. This is a time is bowel disease. Early diagnosis equals better chance of survival. All right. So start your workup. Once the diagnosis is on your radar, you're going to want to do things like getting your patient on the cardiac monitor, getting peripheral IV access, probably ×2, making sure they stay NPO, and you'll probably be ordered to give things like a broad spectrum antibiotic, something like ceftriaxone plus flagyl, or perhaps a dose of Zosyn. What if we either know or suspect there's a thrombosis? Anticoagulation, probably heparin's going to be in order. What if there's already peritonitis or shock? You need a surgical consult now. This is potentially a damage control surgery territory situation. Multidisciplinary involvement, IR, surgery, ICU, early. Don't wait. What else can trip you up? This disease is a chameleon. It can mimic gastroenteritis, pancreatitis, and even an MI. There is plenty that might lead you astray. Troponin and lipase might be elevated. The exam might be misleadingly benign. So you have to stay suspicious. This isn't about waiting for textbook. It's about trusting your gut when theirs is dying. Why do we miss this in the first place? Because we've seen too many simple belly pains. Because common things are common. Because we forget the rare stuff. Because we're human. But every so often, something taps you on the shoulder and whispers, not this one. Look closer. We walk into the emergency department every day and are hit with a fire hose of symptoms and expected to have answers in a time frame measured with a stopwatch. And sometimes the most dangerous thing in that room isn't the disease. It's our assumption that we've seen this before. Abdominal pain can be reflux, it can be gas, it can be cancer. Or in this case, it can be bowel ischemia hiding beneath normal labs, whispering through a mild exam. It doesn't necessarily announce itself. But if you listen, if you remember that complacency can kill, and just maybe curiosity can save, then you won't just catch the rare diagnosis. You'll catch the next chance to save a life. Stay sharp. Stay curious. That's This Emergency Life. We'll see you on your next shift. Take care.